Good morning. Welcome to our first presentation in our Parkinson series. We're really excited to kick it off this morning, and we're in for the next couple of months having presentations every week across the MDT team all around Parkinson's disease. So what to expect in the series, like I said, weekly presentation jointly presented by different disciplines within our team. So we're really focusing on the holistic approach to Parkinson's management. It's going to be evidence-based, but really focus on clinical applications and practical strategies. So this morning you've got myself, Louise, physio and clinical head for neuro rehab, really passionate about movement disorders, have worked with Parkinson's clients in the community in the past.
And I'm Sarah-Louise Higgins. I'm occupational therapist and national head of clinical development. My passion areas are older adults, dementia, assistive technology, home modification. So all works really, really well within the Parkinson's space.
Yeah, for sure. So this morning is really just to set the foundation for the remainder of the series. So we just want to give an overview of the disease itself, a bit on pathophysiology and medical management, but try not to overburden you with that. Sarah's going to look at the subtypes and different ages of onset of Parkinson's disease, and then break down the stages of Parkinson's disease and the progression using the Holden-Yarrow scale, which is how the rest of the series is going to be set out. And then we're going to introduce the key roles and the MDT parts in the PD management. So to start off, what is Parkinson's disease? It's actually the quickest growing neurodegenerative disease in the world. So it's a progressive condition. There's no cure, and it primarily affects motor function, but as we'll see on the next slide, it has a lot more symptoms than just our cardinal motor signs. It's characterized by dopamine depletion in the brain, especially in the basal ganglia, where dopamine producing neurons start to die off. And the cause is unknown, but I'll go into some theories around causes and risk factors shortly. So, like I said, there is cardinal motor signs. It's primarily known as a motor disorder or motor disease. So our cardinal signs of Parkinson's are tremor, so normally a pill rolling tremor that starts on one side, bradykinesia, or that slowness of movement, rigidity, and then postural instability, which generally manifests later on in the disease. It's important to note that by the time these motor symptoms present, about 50% of the dopamine producing neurons in the ganglia have been lost at this stage. But really, they're just the tip of the iceberg. So beyond those motor symptoms that everyone can see, we've got a range of non-motor symptoms. So things like disordered sleep, constipation, impaired executive function and memory issues, apathy, depression and anxiety have a high prevalence among the Parkinson's population. And they also can have urinary dysfunction, hypersalivation, and orthostatic hypotension. This isn't a limited list. There is a lot more signs, but I just wanted to highlight the main ones and how these ones underneath the surface, so the non-motor symptoms, can really have an impact on the individual's quality of life. So who does it affect? It is the fastest growing neurological disorder in the world, like I said, so increasing by about 4% per year. And at the moment, they estimate that there is in and around 200,000 people living with PD here in Australia. There is a slightly higher prevalence of men versus women, and it is primarily diagnosed after the age of 65. But there, as Sarah will discuss, there are younger onsets, so about 10% of PD patients are diagnosed under the age of 45. And they estimate that here in Australia, there's maybe 18% still at a working age at the time of diagnosis, so under 65. Why it's increasing prevalence or growing fast can be due to the aging population, people living longer in general, and also earlier diagnosis and more awareness of the condition itself. So like I say, the causes, most cases are idiopathic, meaning that we're not exactly sure why someone develops Parkinson's, but it is believed to result from an interplay of genetic susceptibility and environmental exposures. There is 10 to 15% linked to genetic mutations, and it's been found that someone with a first-degree relative with Parkinson's disease is double the risk of developing Parkinson's themselves. And environmental, this is something that's getting a lot more coverage now and a lot more research into its role in Parkinson's risk. And because exposure to certain toxins has been associated with increased risk, especially pesticides and herbicides, things in industrial, like heavy metal. And another one that I've not put on the slide there is head trauma has also been shown to increase Parkinson's risk. So looking at a little bit more detail in pesticides and Parkinson's, just because, like I say, it's something that has got a lot more coverage recently, especially in the mainstream media. So it is assumed to be one of the main environmental factors leading to Parkinson's disease. So there's been a lot of studies carried out in the last 40 years, and the results have been varied, but overall the current evidence shows that exposure to certain pesticides may increase the risk of Parkinson's, but it's not actually strong enough to say that it directly causes Parkinson's. But what they have found is that people that have worked in agriculture, live near farms or golf courses where they use a large amount of pesticides have been more at risk or more likely to develop Parkinson's due to that chronic low-grade exposure. Paraquat and rotenone are the two main ones that have been highlighted to put people most at risk, so exposure to those ones. Paraquat has actually been banned in the UK and a lot of European countries since 2007, but it still is used here in Australia and in the US as well. And there's different mechanisms that they have found lead to the development of Parkinson's. So promoting Lewy body formation causes neuroinflammation, mitochondrial dysfunction. Again, they've done a lot of evidence in mice and rats to show how this can cause changes in the brain and ultimately lead to these PD symptoms. So what are the risk factors then? We know that we can't identify direct causes of Parkinson's, but there are some risk factors that maybe put people more in a predisposition for Parkinson's. So like I said, older age. So over the age of 65, people become more at risk of developing Parkinson's, or they're more likely to be diagnosed at this age. Sex, so again, men are about 1.5 times more likely to have Parkinson's disease than women. And again, this is kind of unclear, but they think that estrogen might have some protective role or preventative role for women. Ethnicity, so white and Hispanic people are more likely to develop Parkinson's than Black and Asian ethnic groups. Occupation, like I said, your farmers, people that work in agriculture and industry. Lifestyle, this can be both a preventative and a risk. So people that live a very active lifestyle, people that exercise across the lifespan, have more neuroprotection, so more of a reserve and maybe less likely to develop Parkinson's. So that's again something that's coming out in recent literature and recent research is around the role of exercise in our brain health and preventing these neurodegenerative conditions. Head trauma, like I mentioned, it's not a direct cause. Not everyone that has a head trauma is going to go on and develop Parkinson's disease, but they have found a link there. And loneliness. I'm going to touch a bit on this because it is a study that's come out recently that's quite interesting. So it looked at a large cohort of people in the UK, so almost 500,000 people. They followed up over a 15-year period. And the objective of this study, so it was 2 years ago, 2023, was to investigate whether loneliness is associated with an increased risk of developing PD. So they found that those that reported loneliness were 37% at higher risk of developing PD than those that didn't report. And that's even when they corrected and adjusted for age and sex, socioeconomic status, physical health, depression, social isolation, and genetic risk factors, this link between loneliness still remained significant. So really interesting. It shows that the link between loneliness and PD was not explained just by depression or social isolation caused by the disease itself. It suggests that loneliness itself is a distinct psychosocial risk factor preceding the Parkinson's onset or diagnosis. So I guess the findings of this study really highlight the importance of looking at our clients and our patients holistically rather than just focusing on the biological signs and risk factors. So this is a really high risk factors of psychosocial determinants of health, and really we should be promoting that human connection and social integration across all of our clients, because we know that it does have a role to play in preventing this neurodegenerative disease. So how is it diagnosed then? I spoke about the cardinal signs of Parkinson's disease. So it is a clinical diagnosis. There's no neuroimaging, no diagnostic test at the moment for Parkinson's. So somebody has to have bradykinesia, so that slowness of movement, and one of either a resting tremor or rigidity. So they need to have two of those signs. And then on top of that, they need to have two supportive criteria. So either improvement with dopaminergic medication or levodopa-induced dyskinesia. So I'm going to speak about those when I talk about medication in a few minutes. And then no exclusion criteria or red flags. So some red flags would be rapid progression, symmetrical onset, or severe autonomic dysfunction. And exclusion criteria would be someone that has lower limb symptoms only for over 3 years, but generally diagnosed by a neurologist and based on those clinical motor symptoms, and someone that has a good result from levodopa is generally indicative of them having Parkinson's disease. But a fun fact I wanted to throw in here is there is a lady in Scotland, well, this is a few years ago now, who said that she could actually smell Parkinson's disease. So she was a retired nurse from Scotland and had a really, really sense of smell. So she noticed that her husband had a strange kind of body odor that she couldn't make sense of. And no matter how much he showered, changed his clothes, it was still the same. So a really distinct, musky smell. And he later got diagnosed with Parkinson's, but she'd noticed this years before this diagnosis. So after he was diagnosed and they started going to Parkinson's support groups, she was really overwhelmed with that same smell across all of the people with Parkinson's. So it's something that she spoke to the neurologist about, and she actually participated in a study. So she had a blind test where there was 12 people, 6 with Parkinson's disease, 6 without. They all wore a clean, identical t-shirt to bed that night. And then she smelled them the next day. She was able to pick out the 6 people with Parkinson's disease, and she picked out a 7th person as well that didn't have Parkinson's disease, but actually that person was later diagnosed a couple of years later. So she actually was 100% accurate in the trial. A really interesting story. There's a few podcasts and articles about her, but she has been working with researchers at the University of Manchester and the University of Edinburgh in the UK, and they're trying to use what she's found with like that scent, and they found that there is some proteins and compounds found in people with Parkinson's sebum, so their oil on their skin. So her scent and her sense of smell has been able to identify biomarkers that could lead to non-invasive diagnostic tests. So yeah, really interesting one I just wanted to include. So the researchers are exploring whether they can develop a rapid skin swab to identify those molecules in people's sebum to detect Parkinson's disease. So not a validated test or diagnostic for Parkinson's yet, but something that is hopefully promising for the future. So I spoke a bit about dopamine and the basal ganglia. I don't want to go into loads of detail here on it, but I just did want to touch on the pathophysiology for Parkinson's disease. So we know that the main area of dysfunction is in the basal ganglia. So it's a group of nuclei in the brain that's involved in movement regulation, motivation and reward, mood and cognition, and sleep and attention. So the dopamine is produced here in the substantia nigra. And in Parkinson's disease, we have that progressive loss of dopamine producing neurons here in the substantia nigra. So like I said, by the time we develop those motor symptoms or we can see those motor signs, about 50% of those dopamine producing neurons have been lost. Within the basal ganglia, then we have two pathways. So dopamine modulates these two pathways within the basal ganglia. The direct pathway being movement facilitation. So that's an excitatory pathway where dopamine stimulates it via D1 receptors. That leads to activation of the motor cortex, allowing voluntary movement. And the indirect pathway is the pathway for movement inhibition. So dopamine actually inhibits this pathway via D2 receptors, and it prevents excessive inhibition of movement. So if you think about it simply, it allows smooth movement and inhibits unwanted movement. So together, dopamine modulates those pathways to ensure smooth, controlled motion. So looking here, again, I'm not going to spend too long on this. I've put a link at the end for this YouTube video that goes through it really nicely, but basically the motor cortex wants to initiate a movement, and then the pathways come down through the thalamus, the striatum. So these are all parts of the basal ganglia. Dopamine acts in an excitatory manner to allow that movement. So we get that movement up here. So if we think about traffic warden, it's saying, yeah, go ahead, you can move. Versus the indirect pathway, then we've got that inhibition of movement. So that's dopamine dampens down that response. So we get less movement, and they say, stop, don't let that movement happen. So here again, you can see the direct pathway stimulates and allows movement. So more activity promotes movement. The indirect pathway, less activity, inhibits movement. When we have less dopamine, then there's less movement and there's excess movement suppression. That's where we get that bradykinesia, rigidity, tremor, and postural instability. So overall, there's a reduction in wanted movements, and we're allowing too much unwanted movements. So instead of that nice stop and go for the direct and indirect pathways, we get a bit of a mix up of the signals, and we end up with chaos. So again, that video link that I put at the end in the references goes through it really nicely if you're interested in the different receptors and the mechanisms of dopamine, but I didn't want to overdo it on the pathophysiology for this morning. But going to move on to look at medication in Parkinson's, which is a massive management strategy and something that we need to be aware of as therapists working with people with Parkinson's. So the mainstay of treatment, and will be the first protocol often, is levodopa or L-dopa. Just to say, like I mentioned at the start, there is no cure for Parkinson's, and the medications don't slow down the rate of Parkinson's and the rate of progression. It does just control the symptoms of it. So you might think, why don't they just give them more dopamine? That's what they're lacking in their brain and their system. Why can't they just give them dopamine to increase those levels? It's because dopamine itself can't cross the blood-brain barrier. So they have to rely on precursors or receptor agonists for dopamine. So L-dopa is a precursor for dopamine that's taken in often a tablet form that can cross the blood-brain barrier. And then once it is, it into dopamine by an enzyme called dopa decarboxylase. And that ensures more levodopa reaches the brain. So Often that will be combined with this carbidopa or sorry, I'm butchering these pronunciations, benzarazide, and that prevents peripheral breakdown and conversion of dopamine. So we want to limit the conversion of L-dopa to dopamine once it's crossed the blood-brain barrier. So this carbidopa prevents it being converted anywhere more peripherally, and that can, like I say, ensure more levodopa reaches the brain and also reduces side effects. Timing, this is really important for any PD meds because the goals of the medication is to maintain stable dopamine levels across the day. So we don't want this random taking of the medications where then you get a sudden increase in your dopamine and then it wears off and you're on this on-off period. So on period is when the medication is most affected, your motor symptoms are most under control, and the timings, really the neurologist will play around with these quite a lot to find the optimum dose and the optimum timing to limit the amount of off period that the individual has. So the off period might look like someone is moving a bit slower, their tremor is more pronounced, they're more rigid. So generally the levodopa is taken every 3 to 4 hours. It is best absorbed on an empty stomach. We'll probably have more dietitian input regarding this, but this is important and something that will be explained to your Parkinson's clients, that levodopa is best absorbed on an empty stomach, and protein does interfere with the uptake. And why that is because levodopa is absorbed in the small intestine and then transported to the brain via the same carrier system as certain amino acids, so amino acids from dietary protein. So this creates like a competition between levodopa and protein for absorption and transport to the brain. So if someone has a high protein meal and around their Parkinson's meds, it can delay or reduce the levodopa absorption in the gut. So that can cause a delayed on period or increased off period. Or even if the levodopa is absorbed, the amino acids can compete at that blood-brain barrier. So that limits how much levodopa can actually reach the brain and then convert to dopamine. So something that we might consider in our therapy, we want to be getting someone in their on period as much as we can so that they can engage the most actively in their therapy sessions, but also good to find out from your client what do they look like in their off period. And if it's something that they're really having significant fluctuations in their functions, that the neurologist might want to look at their timing of their meds again. So dopamine agonists, then, they're medications that mimic dopamine and bind to dopamine receptors. So they stimulate the dopamine pathways directly. They don't convert to dopamine itself. And some examples of these are Primic and Ropinirole. These will be probably the second course of action if someone doesn't tolerate levodopa or the effects are wearing off over time. But these medications have been shown to contribute to impulse control disorders, especially someone that's on a dopamine agonist for a longer period. So that's compulsive, repetitive behaviors that are difficult to resist. So even behaviors that have negative consequences. And why they think this is dopamine being a neurotransmitter, it also has a role in reward and happiness. So these behaviors, whilst they can have negative consequences, are often pleasurable or relieving. So common ICD behaviors are pathological gambling, compulsive shopping or compulsive spending, hypersexuality, binge eating, or excessive use of computers. There is lots like hoarding, reckless generosity. So these behaviors, as you can imagine, can lead to financial, legal, social, and emotional consequences. They're often harder to diagnose because there's something that's underreported, and often the person will be unaware that it's related to their medication itself. So they'll rely on family and friends to highlight these a bit more. But yeah, the prevalence can be 10 to 15% in PD patients, especially those under 65 or people that have a bit more of a addictive personality. and people that are on high doses of dopamine agonists. So something to note. The medications for Parkinson's can be quite complex. So you're not going to know every medication, but good to have an awareness of what is out there and what are some of the side effects for these meds. And again, just wanted to touch on DBS, so deep brain stimulation. It is a surgical option for patients with advanced Parkinson's who either have significant motor fluctuations or tremor that has not been controlled by medication. So often people that are really impaired from a motor point of view, and their medication just can't get on top of those motor symptoms. So for DBS, you probably might have seen videos of people where they do it before and after with the device switched off and on, where they have a massive tremor or really pronounced postural instability, and then they turn it on and they walk really well, or their tremor has disappeared. So it works by electrical impulses modulating neural activity within the brain. So electrodes are implanted in specific brain regions, so usually in the subthalamic nucleus or the globus pallidus interna, and it's connected to a pacemaker-like device. So important to note that it doesn't cure Parkinson's, it doesn't slow the progression, or it doesn't help the non-motor symptoms, but it can significantly improve motor function and reduce need for medication or replace medication in those people that medication is not serving its purpose. But patient selection is key. So someone needs to be cognitively intact, have a pretty clear psychiatric history, and their overall health must be sufficient to undergo surgery. Works best for people that have had Parkinson's disease for several years and have responded well to levodopa in the past, but maybe now their disease has progressed and their levodopa responsiveness has reduced. So that was a bit of a whistle-stop tour of Parkinson's itself and the medication and the medical management for it. Again, throughout this series, we'll be discussing and touching on medication and different treatments throughout. So the purpose of this morning is really just to give you an overview and an introduction to get you set up for the remainder of the series. So I'm going to pass over to Sarah now, who's going to speak about the clinical subtypes and staging.
Yeah, perfect. So if we begin by exploring the clinical subtypes of Parkinson's disease, because Parkinson's isn't just a one-size-fits-all condition. It presents differently for each person, as Louise was just saying. Differences are grouped in subtypes based on symptom prominence, age of onset, and progression rate, which we're going to touch on. So for example, as you can see in the table here, tremor-dominant Parkinson's affects around 75% of cases. Typically younger onset between the ages of 45 to 55 years of age, and it progresses slower, much more slowly, and it's reportedly has a better initial response to medication. And as it says in the names, tremors are the most dominant symptom. Whilst if we look at postural instability, gait difficulty, or PIGD, its most prominent symptom is balance and walking difficulties, and it's often associated with a faster decline and a higher risk of falls and cognitive changes. And there's actually some research out at the moment saying that it's less responsive to medication in comparison to tremor-dominant Parkinson's. And in a lot of research, you see a lot about tremor-dominant and PIGD, but there's also bradykinesia dominant as well. So the most prominent symptom is the slowness of the movement rather than a tremor, because the tremor can often be either really minimal or completely absent. So slowness in initiating and carrying out involuntary movements, or movements not only slow but often become smaller, less fluid, and less automatic. And recognizing these subtypes really helps tailor the treatment and anticipated changes. But if we go on to look at Parkinson's across the lifespan, when we think about Parkinson's across the lifespan, Parkinson's can affect people of any age, from children to older adults. Though, as Louise was saying, most common is over the age of 60. However, it's really important to understand how the disease behaves differently depending on when it begins or when the onset is, and how that impacts mobility, cognition, or social roles, and how that varies significantly. So if we start with juvenile Parkinsonism, this typically begins before the age of 21. It's extremely rare. Characteristics, all of what Louise was saying, that bradykinesia, that slowness of the movement, rigidity, tremors, often starting in the hands, and postural instability. The non-motor symptoms, actually some cognitive impairments at this stage, sleep disturbance and psychiatric symptoms, mostly depression, anxiety, and actually impulse control issues. There's also some neurological signs, dystonia, sudden involuntary muscle contractions, some sudden muscle jerks, and also ataxia, uncoordinated movements. With treatment, as Louise was saying, there's no cure. It's usually medications, therapies, psychosocial supports, and in some selected cases, the deep brain stimulation. One thing about juvenile Parkinsonism in comparison to the other subtypes is it's usually down to a gene mutation. And I top of my head, I believe it was PAR1, PAR2, and there was 2 other gene mutations. So in regards to the diagnosis for juvenile Parkinsonisms, there would be some kind of genetic testing as well as the clinical assessments as well. With prognosis, usually much slower than the adult onsets, and many patients have a good quality of life with early intervention. The long-term difficulties is usually medication side effects, psychosocial challenges, and potential for cognitive decline. And then we have early onset Parkinson's disease, which is usually diagnosed between the age of 21 to 50 years of age. And it affects approximately 4 to 7% of all people with Parkinson's. Again, same with the motor symptoms, tremors, although often faster and more variable than older adults. The bradykinesia, the rigidity, but also postural instability, dystonia may also actually appear earlier or also as a side effect of medication itself. Those non-motor symptoms, sleep disturbances, mood disorders, but also within young onset Parkinson disease, there's also autonomic dysfunctions in comparison to juvenile, so blood pressure changes or digestion changes. With early onset, less frequent cognitive decline in comparison to late stage. Treatment's exactly the same, medications, therapies, mental health support, and usually that deep brain stimulation is much more variable in younger patients and within this stage of onset. Prognosis, slower disease progression than late stage, but faster than juvenile. Longer functional independence, fewer cognitive challenges earlier on, but can progress quite quickly. Though in this stage, there's greater neuroplasticity, which allows for better response to therapy. The thing with the young onset, the challenges per se would be they're usually diagnosed during career or family building years. So there's impacts on employment, impacts on parenting, impacts on financial planning. Then we have late onset Parkinson's disease, which refers to Parkinson's diagnosed over the age of 50, which most cases occur over the age of 60 years of age. And it's most common form of Parkinson's disease, as Louise was saying, and typically progresses more rapidly than the younger onsets. Characteristics, all the same for the motor. The resting tremor, bradykinesia, rigidity, postural instability, and frequent falls. Non-motor symptoms, cognitive decline and risk of dementia, sleep disturbances, mood disorders, and also autonomic dysfunction as well, constipation, urinary changes. Within this stage as well, there can be that medication sensitivity that Louise was touching on as well, and also likelihood of side effects from some of the treatment approaches are all the same. Deep brain stimulation can still be used within this space, but less likely with the older adults, and also palliative care integration for the advanced stages, which we'll go on to shortly. So if we go on to just a quick visual of the key differences of onset. As you can see, the main things, progression is slow, moderate, faster. the juvenile is the strong genetic link. Sometimes the young onset can have a genetic link, but late onset, not as much. If we go on to the 5 stages, so bringing all of that together, we have the symptom profile, we have the age of onset. Now we have the 5 stages. Now, the 5 stages, because Parkinson's disease is a progressive neurological disorder that affects the movement and balance and coordination, as we've said, we need to understand its progression, but for years, no one knew how to do that. And that's where the Hoehn and Yahr scale comes in, which is a tool that breaks down Parkinson's into 5 different stages. And the scale was first introduced in 1967 by Dr. Melvin Yahr and Dr. Margaret Hoehn, 2 neurologists working in the US. And their goal was to provide a standardized framework for tracking the severity of the symptoms in Parkinson's patients, from the earliest signs to the most advanced impairments, and developed over time when Parkinson's research was actually gaining momentum. And Hoehn and Yahr scale quickly became a bit of a global benchmark. And today it's used by neurologists, researchers, and people around the world to assess the disease progression, guide treatment decisions, and also support clinical trials. The purpose of the scale, though, isn't just clinical, like it's deeply personal to clients and caregivers, because it helps patients, families, helps them anticipate change, plan their own care, and navigate that emotional journey that they'll be on with Parkinson's disease. So if we go on to stage 1 of Parkinson's disease, is often quite quiet, almost you really notice it. So symptoms are mild, usually unilateral, meaning affecting just one side of the body. And individuals might notice a slight tremor in one hand, maybe some stiffness in a limb, or even change in facial expressions, but only slight. Perhaps it would be a reduced blink rate or a subtle kind of mask-like appearance. Though functionally, most people remain fully independent and they can work, socialize, carry out daily tasks without any assistance. But these early signs can be easily mistaken for stress, fatigue, or even just general aging. And that's why diagnosis at this stage is often quite delayed. Clinically, physicians look for that resting tremor, rigidity, and slowness of movement, as Louise was saying. And these symptoms might be so mild that the person doesn't seek medical help, or even the doctor may not yet recognize it as Parkinson's. This stage is critical window, which we'll be talking about throughout this entire series, because early recognition means early intervention, which can slow progression and improve quality of life. Then we have stage 2, which marks a bit of a turning point because symptoms now appear on both sides of the body or at the midline, affecting posture, gait, and even more of those facial expressions. Individuals might notice a bit of a stooped posture, slower walking, or maybe a soft or monotone voice. Facial expressions may fade and blinking becomes less frequent. And functionally, people can still live independently, but tasks take a bit longer. You know, buttoning up a shirt or writing a note or cooking a meal may require a more effort. Maybe speech becomes a bit more slurred or fades mid-sentence. And clinically, this stage is easier to diagnose. The bilateral symptoms combined with the rigidity, the bradykinesia, paint a bit of a clearer picture for doctors. Though in this stage, there's no balance impairment, which distinguishes stage 2 from the more advanced stages. And this is the stage where people start to adapt maybe their morning routines, seeking therapy, and exploring medication. Stage 2 is more about adjustment, that resilience, and kind of learning to live with the change. Because then we go on to stage 3, which is kind of considered, or it is considered, mid-stage Parkinson's disease. And the hallmark here is that postural instability and a loss of automatic balance reflexes. People may sway when standing, maybe they stumble when turning, or even fall unexpectedly. Movements are slower, multitasking becomes much harder. And although despite these challenges, most individuals remain quite functionally independent. They can dress, they can eat, they can manage their personal hygiene, though these tasks may take longer and require more concentration. Clinically, this stage confirms the diagnosis. Symptoms from earlier stages persist, though intensify. The rigidity, the tremors, the bradykinesia, and now balance issues emerge. and got some physios in the room, whether you guys do this, but doctors will perform that pull-push test to assess the postural reflexes, kind of pushing the forward and pushing them backward to kind of test. This stage is a bit of a wake-up call for clients and caregivers because falls become a real risk, a very high risk, and safety planning is the essential part here. If we go on to stage 4, this is where Parkinson's becomes quite disabling. So people may still be able to stand, they can walk unassisted, but movement is slow, it's stiff, it often requires a mobility aid, walker, chair, caregiver support. Tremors may be less prominent, but rigidity in that bradykinesia is quite dominant. Functionally, independence fades, and daily activities like dressing, bathing, cooking require much more help. Living alone becomes much more difficult, and many consider living in full-time care or having full-time care supports at home. Clinically, the symptoms are unmistakable at this stage, and there's significant motor and non-motor symptoms, as we've discussed before. This stage is emotionally challenging and it demands adaptation, support, and compassion, but with the right care and that MDT holistic approach, which is again the whole point of this entire series. Going on to stage 5. This is the most advanced stage of Parkinson's disease because individuals are often wheelchair-bound, bedridden, requiring 24/7 care. Movement is extremely limited. Even sitting up or standing may be impossible without even assistance. And functionally, the person is usually fully dependent. They need help with every aspect of their life. Eating, hygiene, mobility. Speech may be severely impaired. Swallowing difficulties can lead to nutritional challenges. Clinically, this stage includes severe motor symptoms and often non-motor complications, such as hallucinations, delusions, and dementia as well. The risk of falls, infection, and medication side effects increase even more. And palliative care, emotional support, and meaningful interactions make the biggest difference at this stage. So families and caregivers become that kind of lifeline, and the focus shifts from comfort to comfort, connection, and also quality of life. Then we'll go on to the influences of the prognosis. Again, we're just going to skim through this bit here because I feel like we've touched on this quite well. So the age of onset, the different subtypes, the responses to medication, any comorbidities, cognitive declines, cardiovascular, frailty, worsening of the prognosis, any lifestyle changes or lack of ability to access supports as well, cognitive status, and any form of complication. Thinking of these factors and going on to the prognosis timeline. Now, prognosis timeline, again, will differ for everybody, but kind of the general rule, more so thinking about the later onset population, is usually stage 1 can take 0 to 2 years from diagnosis, stage 2, 2 to 5 years from diagnosis, stage 3, 5 to 10 years, stage 4, 10 to 15, and stage 5, 15 years from diagnosis. But reading literature, this changes, but this is the kind of general rule that I've seen. So continue to look out for that one. Now, why does the MDT approach matter? And everyone in this room knows why an MDT approach matters the most because of the comprehensive symptom management, personalized and holistic care, improved clinical outcomes, support for caregivers, and shared decision making. And that's why we decided to make this series as a multidisciplinary team, just so we can share all of our knowledge to everyone else. So everyone, even out in the community, is aligned with this approach. So who's in the team? Let's just skim through some of the team here. So we have Parkinson's nurses. So their expert guidance, their medication support, ensuring the correct timing and dosage. Again, as Louise was saying, really critical for that Parkinson's med to work effectively and perfect timing. Home visits and accessibility. In many regions, they offer the home-based care to reduce hospital visits to improve that comfort. Education empowerment. They teach families and patients about the condition, promoting self-management and confidence. They do team coordination and also preventative care, falls, infections, skin integrity, etc. Then we go on to OTs. I may be biased, but we're great. We help with maintaining as much independence within daily life. We look at home safety and modifications, whether it's grab bars, whether it's rearranging furniture, using assistive technology to reduce falls risk and improve mobility, cognitive and emotional support, fine motor skills. Fatigue and energy management is a big one, teaching pacing techniques and time management to conserve energy throughout the day. And also there's another consideration for like driving and mobility guidance, which we go on to in stage 1 actually. Physiotherapists, they help with Parkinson's to stay as mobile and as independent. So mobility and movement training, balance and falls prevention, using targeted techniques to enhance that stability and reduce falls risk, especially crucial with the Parkinson's side effects. Strength and endurance building, flexibility and stretching, combating that rigidity with stretches that helps the joint like remain a bit more limber and reduce that discomfort and pain, functional task practice, and also long-term planning. We have EPs, tailored exercise programs, neuroprotective benefits. So regular physical activity may slow the disease progression and improve that dopamine efficiency in the brain. Gait and balance training, help reduce those freezing episodes, improve walking patterns, prevent falls through targeted movement strategies, strength and resistance work, flexibility and coordination, and also mental health boost, because we all know exercise improves mood, reduces anxiety, and enhances that confidence and independence. We also have dietitians, so they help with personalized nutritional plans, medication and timing, and food interactions. So like Louise was saying, advice on how meals affect Parkinson's meds, especially that protein interference. Swallowing and eating challenges, maybe they help with dysphagia by recommending safe food textures and hydration strategies, weight and muscle maintenance, digestive health, and brain and mood support. We have our speechies. They will do the voice and speech therapy, communication confidence, like teaching strategies to stay socially connected, reduce that frustration, and maintain independence in conversation. Swallowing safety, assess that and treat dysphagia, the swallowing difficulties to prevent choking and aspiration pneumonia. Evidence-based programs like Speak Out to strengthen the voice, the speech muscles and promote intentional communication, and also education and support. We have our podiatrists, gait and walking support, footwear advice, routine care, dystonia and pain relief, so helping treat painful toe curling and spasms that's quite common in Parkinson's. Neurovascular assessments, monitoring the blood flow and sensation to the feet to detect any changes early, and falls risk evaluation. We have our positive behavioral support practitioners, understanding behavior triggers, like identifying what can cause distress, frustration, or even withdrawal, especially as Parkinson's affects the mood and the cognition. Person-centered planning, communication strategies, emotional regulation tools, environmental adjustments, and also quality of life, because positive behavioral support practitioners aim to increase engagement and autonomy and joy, not just reduce challenging behaviors. So extremely important. And last but not least, well, for this presentation anyway, I'm sure there's lots of other people as part of the team. We have our doctors and our medical practitioners. Diagnose, monitor, medication management, advanced testing, referrals to specialists, clinical trials, and those non-motor symptoms. So collaboration between professionals, patients, families is essential, and it is key because it ensures that continuity of care, shared decision-making, and better outcomes. I'll pass over to Louise for the key takeaways.
Yeah, just for this morning, I guess the main thing that we wanted you guys to get out of it is just, like I said at the start, an introduction to the disease itself to really set the foundation for the series to come. So hopefully now you've got a good understanding of the stages, as Sarah so beautifully broke down by the Hole in Your classification. And that's how the rest of the series is going to move forward. So next week, we're going to kick off with stage 1. We'll have 2 topic presentations per stage until the final stage. And really, I hope that's highlighted the MDT approach and how we can all work together towards common collaborative goals for our clients with Parkinson's disease. So hopefully this morning has set you up and made you as excited as we are for the rest of the series. A bit of an idea of what to expect. So like I said, 2 topic presentations per stage, and then we've got 3 topics for the final stage, stage 5, because it's probably more complex and more nuanced care required for that. And then we're going to round off the series with an open office MDT discussion at the end. So next week, like I say, so this time myself and Jess Graham, who's our clinical head for early intervention behaviours and exercise, REP down in Tassie, we're going to look at the stage 1 early stage. So looking at assessment, adjustment to the diagnosis and early motor signs, and educating our clients and trying to highlight the importance of self-management and adjusting to the diagnosis. We're going to look at neuroprotection in exercise and trying to leverage off that neuroplasticity to preserve motor function and slow progression. And we've got a quiz here. If you want to use the QR code to do a quiz, you get an attendance certificate for this morning. And otherwise, the link will be on the website as well. And then we have some references here. But yeah, thanks for joining us this morning. I think it will be a really good series and everyone's really enthusiastic and really keen to get it going. And yeah, it really worthy to have such an amazing MDT platform and all can collaborate on a topic like this that really does thrive and really need an MDT holistic approach for best gold standard management of Parkinson's. So yeah, should be good couple of months ahead.
Thank you so much. Thank you. Is anyone on the call got any particular questions? Just disable your mic just in case. If not, we might leave it there.
Yeah, have a lovely day, guys. Thank you.
Thank you. Bye, everyone.
Thanks, guys.
Thank you.